everybody's able to see me here, right? Do you see my thumb and my pinky fingers?
Dr. Asif, one thing.
Yeah.
Move your laptop lid a little towards you so that, yes, we can now see you.
Is it better? Is this better?
No.
Is there any way I can see my own photo over here?
We can. So on the right side of your screen, when I am talking, can you see there's something called no, not there. Besides that, I mean, apart from this menu on the right hand side of this, so you will. Are you able to see any 3 dots anywhere?
Yeah.
Some more. No, not that. They're on the further to the right.
No, these are the only 3 dots I can see. Okay. Do you see the video panel?
Yes, you can say show video panel.
Oh, perfect. This is good. This is good. Now yes. I can see myself.
Another thing, what we will have to do is many people are complaining that your slides are blurred. So when you think you're gonna show the video?
It will come soon.
Okay, because I think we'll have to uncheck the optimize screen share for video clip. Because
uncheck?
Yes, you remember we did that small setting before sharing this optimize screen sharing. So we'll have to do that again so that because a lot of people are complaining that the slides are blurred. Okay,
let me just do it right now then.
Yes.
Let me just do it. Yeah. So I just stop share and reshare, correct?
Yes. Yes.
Okay. Okay. How about now?
Yes, they're clear.
They're clear. Okay, good. So what I was saying is the target, right? So you want to make sure that. So a lot of times what people do is like, look at my thumb. Now look at my like they do like this. Like look at my thumb. Now look at my thumb. Look at my and what all they have to do is move their eye from my thumb to pinky, which is not too big of a distance, right? So that makes a decent size saccade, and that gives you a very good measure, sensitive measure of a slow saccade. Because if you do a big excursion, sometimes that can give you an illusion that they are slow when they're not slow. Then I also keep the object bright. So remember, a lot of our patients are elderly, right? And when they're elderly, they may not have necessarily good vision. And in that case, you have to make your object as bright as possible. I try to keep like red color object, which is typically good for almost everybody. You have to make sure that you check the alignment of your patients. What I do is I keep the occluder on me, and the type of occluder that I like is the one which is more translucent. So if you cover one eye, you can see the covered eye, but the person cannot see out of that covered eye. So that gives you a very good vision. Let's say, for example, if you occlude the eye, as you can see here, this eye is kind of moving in like esotropia. So what you can do if you had occluded this, then you would be able to see it, but the patient would not be able to see out of it. So it's very important to use that type of occluder if you have it, and it's not that expensive either. You can get one for a few dollars. And of course, you have to be very mindful for patients' age. So as you all know, a lot of our patients are elderly, especially when they have neurodegenerative disorders or when they have cerebellar disorders or they have strokes. In these patients, their orbital muscles sometimes get atrophied. And if they get atrophied, they may have
again become blurred. Is there something wrong with the net connection today? I don't know why. It's again become blurred, no, Manasi?
It's interesting.
Yes, sir. Yes, sir. It's become blur again.
Is it jumping?
The slide before this was clear, but this one is now again blur.
Yeah, it had come. Can you just try logging in again, Asif? Maybe.
Sure.
And
yeah.
so if you could also check the internet.
Yeah. So is there some VPN or something connected? Nothing like that, no?
Let me make sure. Let me make sure.
Because when you first we were testing, it was coming perfectly. Now I don't
no, nothing has changed. Everything is the same.
Okay,
on
try
my
logging in
side.
again. Just make sure there's no VPN. And
VPN is off, like logging in using, you mean go back out of Zoom and get back in?
yeah. Just get out.
Okay. Okay.
I don't know. Whatever. Sorry, everybody. Actually, we, tested everything. The questions were also coming perfectly, and video. So I don't know what has happened just now. So we were trying out that Slido also, and that also seemed to work well.
Yeah.
Let's check.
Okay.
No, you did log off.
I did log off and I log back on.
Okay.
Is it choppy? My sound is this choppy or
This
it's
sound
okay?
is okay. Let's try sharing now. Let's see.
Okay. Okay. All right. Okay. Do you see?
Maybe you can
It's still
try sharing your video. That could reduce. Okay. Okay. Start sharing.
I did share. Do you see this?
Yeah, now it's good.
Yes, they are clear.
Yeah. So, interesting. So anyways, we were talking about, actually, I'm going to show my video panel too so that people can see. Okay. So, we were saying that mindful of patient's age because it's very important. A lot of times our patients have difficult time moving their eyes because of their orbital fibrosis, because of the age, which is very common in patients. Deemer and Crane actually did a little study where they looked at some older people, and what they found is as people age, they get two big problems normally without having any neurodegenerative disorder. One is their up gaze get limited, and the second thing is their is there
something is
yes
wrong. I don't know. It starts well, and then after sometime it becomes blurred. I don't know why it's happening.
Do you want to try off of this clicker? Should I just get clicker?
Try without clicker. I mean, I don't
Try without clicker?
Yes.
Because that's the only different thing we did compared to all other talks.
Okay, yeah, try that.
Should I just get out of clicker and see what happens?
Yes.
Okay.
Switch it off.
Okay, I got off clicker right now. How are things right now?
No, it's still blurred.
Interesting.
Can you just check your do speedtest.net, see if your net is become slow for some reason? We can't read at all. Very blurred. Mansi, what could be the problem?
Sir, his internet connectivity.
Is that right?
Hello.
Yeah.
His internet connectivity. I don't see any other problem happening right now, because what I realized is that when he clicked the share, optimize screen share for video clip, and when it became blur, that mostly happens, or rather that only happens when the speaker's internet connectivity is not really strong.
Yeah, I think the speed test is also showing it suddenly slowed down, no?
Yes.
You're not getting.
Interesting.
So if you feel that your cell phone network is good enough, you could turn that into a hotspot, and you could connect your laptop there.
Sure, I can do that.
Yeah, it is not coming only, no? See?
Yeah, it is completely blurred, like nothing.
Hey, the speed test is not showing at all.
Yeah, we need to run it again.
Yeah, let me just do it on outside of this. Give me 1 second. So I just said go here, right? And then it's connecting.
Hello.
Yeah.
Okay. Okay, we can do that. Asif, yeah, we can do one thing. Can you just email me the slides, the PowerPoint, the final one, and I will show it from here and you speak from there.
Oh yeah, and then okay, and then I can just take the okay. Let me try that. Yeah. Good idea. Yeah, 1 second.
That was a good idea by Dr. Shripad. He just called me. I think it's a good idea. So I'll just start it over here. You can stop sharing your screen and just email me.
Yeah.
Okay, everybody, please bear with us for 5 minutes. Should get it on.
So if you want, you can send me the PowerPoint. I could do that.
I
I have to put it on switcher, so it's better.
Oh, right. Yeah, definitely. You will need to have it.
Yeah.
I think even the email might take some time.
Yeah, it's uploading the PowerPoint.
Yes, so because of the speed, that may also take time.
Yeah, it's kind of weird. This is first time it happened like this.
Yeah, but in even 15 minutes back, it was fine.
Yeah, exactly. So, and even weather is not bad. So sometimes with
The
weather it does
surprising part is your video is very clear. Your like we can see you very clearly, but the
yeah, which is weird because if it is speed problem, then I would be choppy, right?
yeah, that's right.
And it is very interesting that PowerPoint is essentially the same PowerPoint that we showed. Like a lot of things are same as what we showed before. So it's interesting.
In the meantime, people can just try posting your questions in Slido. There is a window in your Slido app. When you go to slido.com, next to the polls there is Q&A questions. So you can type your questions till then. Let me see if the questions come in that.
So now I should be able to send you the link. Okay, I got the link.
Is it uploaded? No.
Yeah, I'm just sending you an email right
Hello?
now. Email is coming to you now.
Yeah, okay. Email
You
us
got
now.
it?
Let me get it.
What you could, I mean, somebody from the audience has suggested this, that, so you're at home or you're in the hospital?
Actually, I'm at home right now.
Yeah, so if there is anybody else who's using the internet and...
It's just me.
Anyway, I think
Okay.
it's now come to my laptop, so I will present it from here.
Okay.
You can
Yeah,
see
sure.
it. So
Sure.
his video
Okay.
is good, so
Yeah.
that should not be a problem.
Okay. So then, yeah, so then you can just give me the control of the, yeah, so then I can, yeah.
So in the meantime, you can just tell about the 10 things you were telling.
Yeah, so I don't remember where we yet. I think.
Saccadic, you look at the nose and finger.
Oh, let me tell you something very interesting. So you know Bob Daroff. A lot of people know Bob Daroff, right? So he once told me that why people have problem in up gaze and not in the down gaze. So if you look at like up gaze, that is generally first one to go, and down gaze is not generally first one to go. And why is that? So it's kind of very interesting the way nature has designed us that you tend to see down more frequently than you tend to see up, right? I mean, how many times do you have to see up? But how many times do you see down? While you walk, you see down. While you read, you see down. While you are doing many things, you see down, right? So down gaze is always like saved to go last. It's kind of very interesting. Anyways, I was digressing, but I just realized when we were talking about gaze restriction, down gaze generally goes down less, and Daroff had a very interesting point there. In any case, and then so the next one then was let me pull my PowerPoint to see what was the next one.
Okay, so I think this has come here.
Oh, okay, great. So if you share screen with me,
Yes,
then
yes,
I should be able to get a control.
Okay, so first I share my screen and I hand control to you, right? No?
Yes, yes.
So,
and then I'll have to ask for the control, request remote control, request. Okay. Okay. All right, perfect.
Yeah, okay.
Okay. You guys see my cursor move?
Yes.
Yeah.
Yeah.
Okay, great. So we will talk about that, right? Okay. Very important to stabilize patient's head as you are looking at.
Sorry, I'm just switching off my sound.
Yeah.
Where's my sound? Is my sound?
Okay, it is gone. So I think we're good. So basically, the other very important thing is to stabilize patient's head. It is very, very, very critical. What happens is that a lot of times our neurological patients have tremor, or they have dyskinesias, or they are just fidgety, they are moving their leg or whatever. If you are not stabilizing their head and then looking at their eye movements, then because of this transmitted movement from the body, their head is going to wobble. As a result, their eyes are going to move. So you're not going to get a good eye stability. So in order to kind of get a very good idea for their eye stability, you have to stabilize their head. So what I do is when I examine them, I hold their head like this, the way I am showing, and then I give them the target far away. A lot of times, if I have a fellow or a medical student or a resident working with me, I ask somebody to hold their head as I'm examining the patient. So it's very important that you ask them to stabilize the head. Then another important thing is you pay attention to the eyelid while looking for the vertical nystagmus. So I will show you later on in the slides, but it's when you make any kind of vertical eye movements, your lids move with the eyes because your levator palpebrae is yoked with your recti, which moves your eyes up and down. So every time you look up, your eyelids go up. And when you look down, your eyelids go down. And a lot of times it's much easier to kind of track the eyelids, like especially the lashes, eyelashes, to see up to see the trajectory of the oscillation. So if you look at, for example, subtle downbeat nystagmus, you will see the lid will kind of have upbeat also. So it's a lot of times it's much easier, and I will show you in the video how easy it is. So pay attention to the eyelid. If you don't really see an oscillation, and if patient has complaining of some kind of oscillopsia or some kind of jittery vision, then I want to use ophthalmoscope, because a lot of times eye movements can be tiny, like in the range of less than a degree, and they can be symptomatic, but you cannot sometimes see it with naked eye. In that case, if you look with the ophthalmoscope, you can see the disc movement. And if you see the disc movement, that will be indicative of their eye oscillations. Now, I have to say one thing. When you look at the disc movement, would disc movement be in the same direction as the eye, or it would be opposite? Let's say if somebody has upbeat nystagmus. So if they have upbeat nystagmus, would their lid disc beat up, or it would be down? It would be down, right? Because eyes move like this, and disc is on this side. So eyes are moving like that. For example, this is front, this is back. So if eyes are beating down, the disc is beating up, right? So when you look at the disc beating would be in the opposite of the eye beating. So you want to transform it opposite, right? When you look at the upbeating disc is actually downbeating eye. And as a result, a lot of times fundus exam is considered poor man's Frenzel goggle, right? Because Frenzel goggles are generally quite expensive. Now, actually, Professor Stoop has come up with a new design, which you can get for 100 euros, but typically they used to cost in range of like several $100s. But if you don't have that, you can always use ophthalmoscopy to look at the fundus, and you can get as much of information as you can get from Frenzel. So it's not really a big problem if you don't have Frenzel. And of course, a lot of times you see very subtle disconjugacy between right and left eye. For example, you get, for example, internuclear ophthalmoplegia and if it is robust, you will get it. There's no question. But if it is really subtle, then you may not appreciate it. So in order to appreciate it, what you want to do is you want to look at patient's bridge of the nose right here. And then you look his right eye with your left eye and vice versa. When you do that, your brain will be able to process very subtle disconjugacy, and it is very helpful. And you can sometimes you can see asymmetric amplitudes of nystagmus on two sides. For example, some patients who have seesaw nystagmus, you can appreciate that too. So let's see if you can find the correct answer, which is pertinent to Saccades. I think we can try that switch again, Dr. Kotari. Are you able to hear me? We are trying to do the
no, I'll have to take the control again. 1 second.
oh, okay. While he's finding the clicker. Oh, okay.
Magnetic switcher. Okay, now
I think you will have to click on this meeting, right? So yeah.
Remote control on. Okay, now let's. Yeah.
Okay.
So
the next one. This was the old one, right? We have to do the next one. The next question. This is the one of the, yeah, that's it. So select the correct answer. Saccadic is necessary for clear vision. Saccadic is necessary to shift gaze. Perfect, great. So
okay, shall I view the result?
okay, yeah. So basically, everybody's right who said Saccadic is necessary to shift the gaze. Of course, gaze holding is necessary for clear vision. That is also true. Saccadic is also necessary for clear vision, and we will show you in next slide why. And then the wrong answer is there is no Saccadic during gaze holding. Actually, believe me or not, although it's called gaze holding, you see what we call fixational eye movements, which are type of saccades, which are present during gaze holding, during fixation. It kind of sounds like oxymoron, that it's fixational saccades, but they are there. So let's go to the next slide.
Yeah.
Okay. Okay. What I want you to do as you are looking at this screen, I want you to focus on the black plus sign. As you're trying to focus very closely, not look around, just focus on the black plus sign. What you will see is you will see that purple dot disappearing. Now, what happens as you are seeing that plus sign and that purple dots are disappearing? What happens is you are not making miniature eye movements, which what we call microsaccades. And as you don't make it, you get visual fading. So actually, I may have to ask for the remote control again.
Yeah. Okay.
So yeah. Okay, great, perfect. What happens is during natural viewing, eyes are never ever still. You see miniature eye movements which are present even during fixation. And then what happens as a result, there is a retinal image which falls on a different foveal receptors. Why it is important? Because if retinal image keeps falling on the same foveal receptors, let's say if you're looking at some that little plus sign constantly and your eyes are not making any movement whatsoever, that means only one foveal receptor is active. And when that happens, your foveal receptor will get adapted and you will get functional blindness. So you want to prevent that retinal adaptation when you are viewing the stationary object. That way you prevent functional blindness. So it's very important while you are holding your gaze, you make tiny eye movements. Now, what you will see in the next slide as you are trying to view this little image of these puppies, your eyes are moving in different directions. And what I'm plotting here with the black lines are jumps from one place to the other. But as you see here, you are making tiny, tiny movements. You see this little black here? These are the miniature movements that you're making during gaze holding. So what happens is that as you are looking, you are making big shift from one place to the other, what we call saccades, and those saccades are necessary to shift your attention, right, from one place to the other. And as you are looking at this place, you are holding your gaze, you are making these micro saccades while gaze holding, and you are capturing the vision. It's gaze holding not only keeps the eye stable, but you're also capturing the image well, right? So that brings us to the next question. So clear vision is affected by all except.
Okay.
Okay, so good. I think people got, most of the people got right answer. So what happens is congenital nystagmus is the only form of nystagmus where people don't have any problem with vision typically. The only issue congenital nystagmus. Do we know, probably we never discussed this before, right? So what happens in congenital nystagmus is that there's something called foveation period. So as eyes are moving, this congenital nystagmus, the eyes move in a very funny, weird trajectories. And just during that trajectory of that oscillation of the eye, eyes slow down for a very short period of time. So what happens, your brain gets just enough time to capture the information about your surrounds from that little epoch. And then what it does, it samples from, let's say, 10 milliseconds here, and then 10 milliseconds a second later, and then 10 milliseconds after that. So it captures the image over time, and it just kind of extrapolates that to come up with actual image. So congenital nystagmus really does not create any problems with the vision. And the only problem that it can sometimes create is what we call null. In certain positions, congenital nystagmus is less. So let's say, for example, some people have less congenital nystagmus when their eyes are all the way to the right in the orbit. So as a result, what they do is they turn their head left like that, and they get this weird head posturing. To prevent that weird head posturing, people intervene. Otherwise, generally, they don't intervene. Everything else creates a problem with the vision, okay? Everything else can be classified in different categories, which is the reason for unsteady gaze, right? So one of the categories is, of course, what we call jerk nystagmus. So what happens in jerk nystagmus? So this patient has jerk nystagmus, and what you see here, oh, okay. So what you're seeing here is that her eyes are has jerky sawtooth type of movement. It kind of like jerks to the left side. You see that? It kind of beats to the left side, and it kind of drags or drifts towards to her right side. See? So this is classic jerk nystagmus. it looks it looks as if it has slow and a quick movement. So the drifting movement to the right side are slow movement, and this beating movement, which is to her left side, those are quick phases. So jerk nystagmus always have quick phases and it has slow phases. Okay. The second form of nystagmus is, oh, what happened? Did we lose the screen? Okay, perfect. The second form of nystagmus is your pendular nystagmus. It is getting blurred again to me. Is it blurred to everybody else? Or maybe not. The video looks good actually. So as you can see in this patient, she has another form of nystagmus where you don't see any quick phase or a slow phase. I'll play that again. So what you can see is that she has some sort of a pendular movement, like everything is slow phase. There is no quick phase here. It goes more like a pendulum of a clock, and hence it is called pendular nystagmus. Then what we see certain form of square wave jerks. And we will go to everything in next slides. But what you see here is that this patient has a small saccade to the right and then goes back to the left, and then it comes back to the right. And I will play that again. See that it goes to the right, then it goes back straight, then it goes to the right. So it basically, if you look at the eyes, they go like this. You see my hand here? That is your square wave jerk. And then what you see is what we call saccadic oscillations. And a lot of you probably remember this video from one of my talks where a very young child has this chaotic eye movements. There is no quick phase, there is no slow phase, there is no clear pendular component, but they're just all over the place. And they're quite robust. You can't miss them. And what we call this saccadic oscillations or obsoclonus. Okay. So these are 4 typical classes of eye movements that we will go over. So which of the following is true about what we call saccadic intrusions? Okay, so basically, square wave jerks are type of saccadic intrusions. They do disrupt your gaze. They are uncalled for. Opsoclonus is also one of the type of saccadic intrusions. The only interesting thing about saccadic intrusions is they are typically, when they're abnormal, you can see that with the naked eye. So you can see that during the examination. And vestibular system generally is not known to have any specific direct influence on saccadic intrusion. So those 2 are not true. Everything else in this slide is correct about saccadic intrusions. And we will get into the details in next slides. Okay, we are ready for the next slide. Okay. So saccadic intrusions. So what happens? Saccadic intrusions are actually a form of these miniature fixational eye movements, but they are actually too big. And they're not only too big, but they are uncalled for. So, so typically, let's say if I want to look at from the right side over here to the left side, I make a little saccade, right? But if I'm trying to focus on this S over here and I make an intrusion and my eye move to another N over here, that actually creates a problem for me to read, right? So they are too big of a movement and they're uncalled for. So that's why they're called intrusions, right? They just intrude. There are two different types. One is the square wave jerks and second saccadic oscillations. And we will get into the details why what is called what. So which of the following are the true facts about the square wave jerk? Okay. Okay, so only two of these are true, right? So the name actually comes from the shape on the VNG, and I will show you in next slide how. And also they are generally more robust into PSP compared to normal. They are typically they are always horizontal. It's very, very, very rare. I've only seen one person with vertical intrusions. I don't even know whether we can qualify the definition of square wave jerk. So by book definition, square wave jerks are always horizontal. And typically, if they're not very big, then typically they don't disrupt vision. If they're reasonably big size, that it shifts eyes significantly, then it will disrupt vision, but it's not always the case. So that's why we said that that's not always. So why it is called square wave jerks? So it is based on the VNG. So what line you are seeing here, this is your eye position on the VNG. When this line moves upwards, it moves the eyes to the right, and when it moves downwards, it moves to the left. So when somebody has normal eye movement and looking straight ahead, you will see some straight line like this in VNG. Now, if you get intrusion, then what happens? Your eyes move up like that, then it stays, which means it moves to the right over here, right? Then it stays there in the right side for approximately 200 milliseconds or more, and then it goes back to the left. So if it was a normal person, it would be straight like that. Instead, you are looking to the right and then staying there and then coming back to the left, which gives a little jerk, which has a square shape like a box. That's why it's called square wave jerk. Okay, so again, to revise, they are not always pathological. You can see square wave jerk in normal people. In normal people, you can see up to 50 per minute, so it is possible. In normal people, do size matter? So when they are bigger than a degree or two, then I would start thinking of that being abnormal. And previously, people have asked me a question that whether by looking at the patient by eye, whether I can call whether this is big or small. Answer is after seeing hundreds of patients, And after looking for this in hundreds of patients, probably I can make a little guesstimate, not estimate. But if it is robustly big, then yes, you can say. Otherwise, if you want to really measure the size, then you need to have ENG. But if you see several patients, then you can probably have some assessment that, oh yeah, this is big or this is not big. And then of course, the last, it's always horizontal, remember that. Square wave jerks are two types. So in this case, the eyes are only moving to the right, then staying there and coming back. So that is called monophasic because it has only one phase to the right side. But sometimes square wave jerk move to the right, then it goes back to the left and then comes back. So then it has biphasic. One square wave is to the right side, as you can see here, and second to the left side. That is biphasic. And sometimes you see chains of these back to back, and that's also a form of a square wave. So basically, if you think about microsaccades, which are your fixational eye movements and square wave, they generally are in continuum. So these are like a small square wave jerks, and this is tiny microsaccade here in a controlled patient, and as or normal person. And in Parkinson patient, you see a little more of those. If you look at the pre-SP, progressive supranuclear palsy, you see this size over here, they're taller. That means they have a bigger size. Same thing applies to corticobasal ganglionic degeneration, and in multiple systems atrophy, they're also present, and they're quite frequent, and sometimes they're also big. So typically, they are present in normal people. They may increase in size in certain forms of neurodegenerative disorders. So this brings to a question. I'm going to show you this video, and you have to tell me, focus on the video first, and then you can tell me what this patient has. So what did you see here? Okay. So so the eye movement in these patients are actually square wave jerks, right? A lot of people said gaze-evoked nystagmus and ocular flutter. That means we need to, in the next slide, we need to differentiate one with the other, okay? So now this is the next slide. What is the eye movement in this person? There. So what was that type of eye movement? Okay, so in interest of time, I'll move on. So what a lot of people said ocular flutter. Yes, it does look like ocular flutter because it is horizontal. But if you look at carefully, this patient also had some vertical component. What that means is she not only had just ocular horizontal saccadic oscillations, what we call, it was actually opsoclonus, which had some horizontal and vertical component. So that brings us to the next question. And yeah, so that brings us to the next question. You want to find the wrong answer now. Okay. So okay, so in interest of time, I'll move on. So the wrong answer is opsoclonus is not a disorder of saccade, while square waves are. Actually, opsoclonus are called saccadic. They're forms of saccadic oscillations, right? So they are actually a disorder of saccade, just as square waves. So the difference between square wave and saccadic oscillation is this. So square wave, as you know, in VNG, it looks like this, right? So you get the eye, which goes to your right side. It stays there for about 200 milliseconds. It comes back. So it gives you an appearance of square wave, like a box on BNG. While if you measure, and of course, it's not always pathological, right? And it is up to 1 per second. Now, if you contrast that with saccadic oscillations on VNG, what it looks like is that the eyes move to the right, but then immediately, without any intersaccadic interval, it moves back to the left and then it goes back. So there is no intersaccadic interval like this. And you can easily see that it appears like this. While if you look at the square wave, it's like this. So that's the key difference between saccadic oscillations and square wave. The other difference is saccadic oscillations are can be pure horizontal. When they are pure horizontal, you call it ocular flutter. And when they are horizontal, vertical, and torsional, when they are more than one directional together, they look more chaotic, like Our Lady. In that case, you call it opsoclonus. So saccadic oscillations are two types: ocular flutter when they're pure horizontal, and when they are three-dimensional, they are called opsoclonus. They are generally very fast and they're always pathological. The frequency is about 15 to 40 per second, so they're very fast. In contrast, square wave is about 1 per second, so you can easily differentiate them based on their frequency. Next question, saccadic oscillations can be caused by. This is a very easy question. So I think everybody's going in a very right trajectory. It can be caused by all of them except the stroke in the basal ganglia. So that's the correct answer. It cannot be caused by stroke in basal ganglia, but everything else can cause saccadic oscillations. So we'll go to the next slide now. So one of the common causes of saccadic oscillations is structural deficit, for example, impairment or degeneration in the cerebellum. But another commonly found deficits is something goes wrong with the ion channels in these cells, which controls eye movements, right? And that can happen either in form of a familial disease, or it can happen when you have some kind of cancer and paraneoplastic antibody. So for example, this is one patient who had a channelopathy in their inhibitory channel. This is a daughter and mother.
Look at my finger. Just look at it. Look right at my finger.
So in this video, what you see is like every now and then you see those little jitter in the eyes, like you see my hand here, like that. That was saccadic oscillations. And in the next video, this lady had a cancer. And then she had like episodes of rather faster oscillations of the eyes, but not a lot of them, like 1 or 2, but then it would stop intermittently. And they were also a form of saccadic oscillations. What's happening? So towards the end, what you are seeing is little eyes are doing like that. Those were the brief episodes of saccadic oscillations that she had. So she actually had ovarian teratoma, and then she was diagnosed with syndrome of increased NMDA receptor antibody. So that brings to the next question. Our patient had some sort of problems with inhibition, but what happens in NMDA? Why these people get antibody? So the answer is actually too much of excitation in NMDA receptor antibody that can cause opsoclonus. And then the explanation is as follows. So what happens is NMDA receptor antibody binds to glycine binding domain, which is inhibitory domain, but it binds to the glutamate receptor. And what happens is that it activates the glutamate receptor, which has an excitatory function for the cell. So what happens because of that, the eye movement sensitive burst neurons, they become hyperexcitable. Okay, and they have less effects of external inhibition. So basically, overall, there is too much of excitation, and that then lead to opsoclonus. Okay, and the same phenomenon, same concept also applies to seizure, for example, in the patient who get NMDA receptor antibodies. So it's actually opsoclonus in these patients is because of too much of excitation. And of course, as you treat any tremor disorder with beta blockers, saccadic oscillations can be treated with beta blockers. I had several patients who had idiopathic forms of saccadic oscillations with limb tremor. We gave them beta blockers, and it did work very well. Propranolol worked very well for these patients. So this is a tough question. What you see in this is the eye movement trace in the VNG. So as you may recall, if it is a straight line like this, that means eyes are straight, normal, okay? When the line goes up, it means it is moving to the right. When it goes down, it is moving to the left. Which of the following, remember this picture, which of the following is sign of gaze-evoked nystagmus in video nystagmography? A, B, C, or none? So a lot of people got the correct answer, which is good. So if we go back to the slide, B is the gaze-evoked nystagmus. So what we see in gaze-evoked nystagmus, as you may recall, it has a slow phase. So eyes slowly drifts here. You see that? It drifts to the left side. And there's a fast corrective movement. And then it slowly drifts here and then fast corrective. So this nystagmus, actually, the word is a Greek word, right? It came from like two things, like a moving flag, like flag moves like that and it comes back, right? When it is blowing in the air, that's one. And the second is when you are having the horse, it kind of like goes down and then you do it back, right? When you're riding a horse. So that's slow component, the fast component. So nystagmus, what you are seeing, gaze-evoked nystagmus, for example, the slow drift of the eye movement away from the desired location and rapid correction. So this rapid movement, quick movement are called quick phases, which is corrective, and the slow movements are the drifts. Slow movements are always pathological and the quick movements are always normal. But when we talk about nystagmus, when we say right beat nystagmus, beat is always the quick movement. So we kind of call it based on the physiological component, but it's actually quick phases are physiological, slow phases are pathological. One thing to remember about it. And it does look like a sawtooth when you look at the video nystagmography. So that is the sign of gaze-evoked nystagmus, sawtooth appearance. Remember that.
Asif, we may have
Yeah.
to speed it up a bit because we're running behind time.
Okay. So in this video, we will actually for some reason is not okay. That's fine. So basically, what happens in gaze-evoked nystagmus, when your gaze is straight ahead, you don't see any nystagmus. When you look to the right side, your eyes beat to the right. When you look to the left side, your eyes beat to the left. When you look up, your eyes beat up. When you look down, your eyes beat down. And when you look to the side, your eyes beat, for example, down and to the right, your eyes beat to the down and to the right. And same with the other directions, right? So its direction depends on the position of your eye within the orbit. Okay. Now, remember, look at this patient's eye movements and you tell me what this patient has. So of course, I'm going to tell you this patient has downbeat nystagmus. But I'm going to expect you to tell me the diagnosis. Watch her gait. So I'm not just going to play there. You can just, so, Any takers? Okay, so this person actually had stiff person syndrome. Chiari malformation, of course, can cause, it's one of the classic cause for downbeat nystagmus. But in this person, when she was walking, as you can see, she was very stiff. And of course, that was one of the triggers. The stiffness was the triggers which triggered the diagnosis of stiff person syndrome. What is the most common cause of downbeat nystagmus? Okay, so I think everybody is in a right trajectory. Idiopathic is the most common cause of downbeat nystagmus, and multiple sclerosis, stroke, SCAs, they all can cause downbeat nystagmus, but 60% of the downbeat nystagmus is actually idiopathic, as you can see in this slide. So in nutshell, what happens in downbeat nystagmus, when your eyes are all the way up in the orbit, they are very stable, right? So this is eye in orbit position up. When they are looking straight ahead, you will see beat down. And a lot of times when they are looking to the right or to the left, they would actually beat to the left and down or right and down. So it would be like this, right? And then as they go further down, they get much stronger, like they get much faster beating. So the eye in orbit position actually determines how intense the downbeat nystagmus is, and it gives you a lot of times, it gives you very helpful hint. Now, where does this nystagmus come from? So what you saw in this patient is that the direction of nystagmus was changing, right? So it's periodic alternating nystagmus. Where does periodic alternating nystagmus comes from? So I think people are in a very correct trajectory. Downbeat periodic alternating nystagmus actually comes from posterior vermis, which is nodulus. Actually, we need to go to the next slide. Oh, sorry. So in this patient, what we are seeing is that she had a tumor in the nodulus over here, posterior vermis, which was causing periodic alternating nystagmus here. So this person has stiff person syndrome, and I'm going to tell you
some of the questions wrong answer.
Yeah, I will tell you guys the right answer. This is the person who had downbeat nystagmus and something else. It is not playing. It's not playing for some reason.
Look at my nose here. Look down.
Oh. Okay. Okay. This lady had stiff person syndrome, and you have to tell me what was the mechanism.
Nose, finger, nose.
Slow going.
Yeah, seems like it was finger, nose, finger, nose, finger. Look at my nose here. Look down. Nose, finger, nose.
Slow going.
Yeah, seems like it was finger, nose, finger, nose, finger.
So I'll tell you, you can see that she had downbeat nystagmus and she had opsoclonus. So let me take hers. Okay, so it's too little inhibition and too much of excitation. These are the two reasons why they get that. And in the next slide, I'll explain you how. So what happens is that those who have okay. So what happens is people who have stiff person syndrome, anti-GAD antibody is the one level which is high, which blocks your GAD. What GAD does is GAD actually helps converting glutamate to GABA. So GABA is your inhibitory neurotransmitter and glutamate is your excitatory, right? So when there is an inhibition of GAD, glutamate is not converted into GABA. So there is too little GABA in the cerebellum. As a result, there is a reduced Purkinje neuron inhibition and you get downbeat nystagmus. So too little of inhibition that can cause downbeat nystagmus. And in the contrast, when you have this antibody, there is too much of glutamate because it is not converted to GABA, and excessive glutamate then creates hyperexcitable burst neurons, and then it causes opsoclonus. So that's why there's too much of excitability causes opsoclonus and a little bit of inhibition cause downbeat nystagmus. Okay, so this is a patient. Dr. Kutari, would you be able to play this because I'm not seeing the play button here. It's hidden somewhere. Thank you.
Okay, ऊपर देखो, यहाँ देखो मेरा उंगली इधर.
So of course, this patient had upbeat nystagmus, right? So what is not a common cause of upbeat nystagmus? Not a common cause. I think we are going in the right trajectory. So idiopathic is not a common cause of upbeat nystagmus. Typically, it is seen in patients who have stroke or Wernicke's encephalopathy or even multiple sclerosis. We'll go to the next slide. Okay, so upbeat nystagmus is completely opposite of downbeat, right? So what happens when your eyes are all the way down, like down eye in orbit position, it is stable. Then when you are straight ahead, you see upbeating nystagmus. And when you look to the right or to the left, it may be in the pockets like this, oblique. When you even look further up, it becomes even stronger. So this intensity of nystagmus increases as eyes go from below to above. In contrast, in downbeat, it increases as you go from above to below, right? So basically, whenever you have a patient with a stroke, for example, in the posterior fossa, and you get nystagmus, what you do is you do stroke prevention with antiplatelet and statins or anticoagulation. And you don't generally do anything for nystagmus, which improves in 72 hours, typically like 48 to 72 hours. If, God forbid, it does not improve, then what I typically do is I start them on baclofen, sometimes 5 milligrams 3 times a day, and then gradually escalate that. If that does not work out, sometimes I give them aminopyridines, and that can help. If that does not work out, I try medication called levetiracetam. We come as Keppra brand name in America. Then I have also tried lacosamide in some patients. Of course, these are a little expensive and it's hard for me to get by insurance companies to get them pay for that. But clonazepam actually is very effective in treatment of post-stroke nystagmus, which is refractory. The only problem with clonazepam is that a lot of patients feel drowsy. So if your patient does not feel drowsy, then clonazepam is actually a very good choice that quite effective compared to other options. And sometimes this nystagmus after stroke can become episodic. So they get better within 72 hours, but then if they are under stress or they get some kind of infection or UTI or pneumonia or anything, it can make them decompensated and nystagmus comes back for the transient period of time. And then it again gets better as they get better. So what we call recrudescence of the stroke can also manifest with worsening of the previous nystagmus. So this is something that you need to look out for in patients who have stroke. Okay, this is very interesting. I'm not going to ask you a question because this is a trick one. I want you to characterize this phenomenology. See her lids? So actually she has what we call lid nystagmus. So they were actually correlated with periodic epileptiform discharges from the parietal eye field. So this was her lid EMG, and these are the plaids coming from the parietal lobe, and they correlated with the plaids. It was quite interesting. And they were actually blinks, which were kind of triggered by this parietal lobe. So I call that ictal blink. Let's see. Okay, so blinks are also very useful. I was telling you, like, you take a look at people's eyelids, right, to look for the subtle. Look up. I mean, look straight down. Look up. I mean, look straight down. So what you're seeing. I mean, look straight down. So what you saw in this video is that whenever she has downbeat nystagmus, but you can see that downbeat nystagmus so robustly when you pay attention to her eyelids. So a lot of times, if you pay attention to the eyelids or eyelashes, you can pick up subtle forms of nystagmus. Okay. Which of the following vision problems are seen in patients who have Parkinson's disease? I think we are going in a good trajectory. They have blurred vision, they have difficulty in reading, perceiving depth, double vision. Looks like you guys have read that neurology paper which came out. Oscillopsia and ocular flutter are generally not seen in Parkinson patients. So this is right. What is true about microsaccades in Parkinson's disease? Look at this guy here. He's looking for his wife. Okay, so they're inappropriate in search or direction, they're excessive, and sometimes they're large. So these are the three key features of patients with Parkinson's disease and microsaccades. Now, what happens in Parkinson patient? I'm going to tell you to look for loaf of bread in this picture. And as you look for loaf of bread, what you're doing is you're looking at fridge, you're looking here, and the transit time that your eyes have made in different locations is shown in green. But then finally you found the bread here, and then your gaze is stuck over here, which shows by this red heat map, right? When you ask Parkinson patients to do that, what we are seeing is they are actually looking all over the places. They're kind of seeing wrong places. They are looking for wrong places and their eyes are getting stuck somewhere. It gets stuck on the toaster oven here. And as a result, they are not even able to find the bread. So what happens for Parkinson patients, eyes only see what their mind is prepared to comprehend. So for example, for them, they think that, oh, the bread should be in the toaster oven. Although it's not there, they keep going there, right? So that's a big problem. So they have a problem in executive functioning to execute the right movement in a right way. And that also includes saccade. So what happens that in Parkinson patients, they make 118 saccades to really look for the bread. They could not find it, while healthy subjects made 17 saccades, and there we go, they found one. So that's the difference in microsaccades in patients who have Parkinson's disease. Now, the second question then is, what is true about amblyopia? I know it's on a very different pole than Parkinson, but there is definitely some similarity. So we can I think people are doing quite good. So all of them is actually correct. It can be caused by uncorrected strabismus. It's very common. It can be in young children, can be caused by refractory error. All of them are true. So the next question then is, what is the difference between saccades in PD and amblyopia? So we can go to the, yeah. Looks like people remembered my talk. That's pretty cool. So saccades and amblyopia are too few. So that's the big difference between PD and amblyopia, because in PD you have lots of saccades. So you may remember this from last talk. There are some differences between picture on the right side and the left side. When I ask some healthy people to make the difference, find the difference, and I time them, what happened is that healthy control made, they found about 5 picture differences, which were correct. they took about 4.6 seconds from one to the other, and they make about 35 microseconds to find the difference. Now we tell the same thing to somebody who had moderate amblyopia. These people could find only 3 differences. They actually took 3 times longer time, and they had only 12 microseconds, less than half of the, substantially less number of microseconds. And in those who had severe amblyopia, the picture difference were 0. They could not identify anything, and they actually made only 7 microseconds, or less than half of the microseconds than what normal people did. So what happens in amblyopia is actually their other eye is actually looking normally. It has normal visual acuity, but they still have difficulty in searching the object. And especially it's a big problem when they have to find an object within the crowded scene, what we call crowding. Right? So it's very typical for these people not to be able to find little objects, and that gives them substantial difficulty in gazing in a natural environment. And we think that this could be because of their inability to make adequate number of microseconds. Now, characterize the phenomenology in this patient. So he, as you can see, he had very subtle oscillations of the eyes. I think people are going in a right trajectory. In the interest of time, this patient had pendular nystagmus. He had multiple sclerosis. Next slide. So what is the difference between pendular nystagmus? So this is your pendular nystagmus, and this is your saccadic oscillations, right? So if you look at both, they look about the same. They're oscillatory, right? They're not jerky. So jerk nystagmus, you can see like that, or they are not like they're not like this, right? So they're always like that. So the big difference between pendular nystagmus and opsoclonus is that opsoclonus or flutter is very fast. In contrast, pendular nystagmus is relatively slower and it is bigger. So approximately 5 hertz is the frequency for pendular nystagmus, while this is about 15 to 30 hertz in frequency. So this is the biggest difference between pendular nystagmus and opsoclonus. Now, what else would you look at when you see this person? I want you to look at his bridge of his nose. And you will be able to tell the difference between 2 eyes. Can you tell the difference between 2 eyes? What you would see, what else you would look at this person? You would look at the throat. So this patient had actually syndrome of ocular palatal tremor. And when they have palatal tremor, you will see something like this. Dr. Kothari, can you please play this because my thing is hiding. So here you will focus here. You will see the palatal tremor, oscillations, pretty classic. So when you will see disconjugate coarse oscillations in the eyes, you always want to look at their tremor. You will see syndrome of ocular palatal tremor. Pretty classic etiology. So what you see in patients who have oculopalatal tremor is that they generally come with a stroke into the posterior fossa. This stroke in this patient had atriovenous malformation, which bursted. He had a bleed, and when he had a bleed, it actually disrupted central tegmental tract. What is central tegmental tract? It is one of the limbs of the Guillain-Barré triangle, which is a triangle of fibers which connect inferior olive to the deep cerebellar nuclei. From deep cerebellar nuclei, it goes towards the red nucleus through superior cerebellar peduncle. It does not synapse there, but it just loops around there, going back to the inferior olive. And as it goes there in the central tegmental tract, there is a lesion. If that happens, your inferior olive gets hypertrophied, as you can see that, and then you get OPT. So this is actually end of my talk, and I want to go over those 10 rules again. They are over here. Be sure to have preliminaries, keep distance between the patients so that they don't make convergence, keep your visual target bright so that they can see, check for the alignment, mindful for patient's age, stabilize patient's head, pay attention to the eyelid, look for the subtle vertical nystagmus. You can see that with the movements of the eyelashes. If you don't see any eye oscillation, use ophthalmoscopy. It is fundus examis Poorman's Frenzel, and look at the bridge of the nose to look for the subtle disconjugacy. That, thank you very much. It was a pleasure, and I'm open for questions.
Now you can just add any question, I mean, anything that you want. I mean, just give your comments. And any suggestions. Okay. Okay. I think let's take the questions. Also, we can take in this. I'm just going to take the questions which are there. So let's go to the questions. How do you go there? 1 minute.
I think from here.
I'm not able to get 1 minute. Huh? Yeah. Okay. So what's the reason for, you can see the questions.
Yeah. So what's the reason for periodic alternating gaze? So I believe that they are asking why you get PAN. So it's basically the adaptation time constant, which is a mathematical phenomenology which is under control of nodulus. So what happens is if you don't have nodulus because of lesion in the cerebellum, for example, it becomes hyperexcitable because it's disinhibited and because it's in the vestibular nuclei, which gets your inhibitory tone. As a result, its system oscillates slowly at the rate of about it finishes cycle once every 2 to 5 minutes. And as a result, you see the oscillation in the gaze orientation. So that's why it's periodic alternating hashtag. Please clarify the distance between patient and your hand for checking saccades. It's actually the target, which is not my hand, which is generally far. I typically try to keep it about 6 feet generally. And then I am sitting on the side. So when they're looking at the side, it's not necessarily always 6 feet, but of course, the straight ahead target is generally 6 feet, 6 to 10 feet. We use OKN to diagnose functional visual loss. Is it the best method? I mean, well, I mean, I generally don't get patients with functional visual loss because generally they go to the ophthalmologist, but sure, it is possible. You are basically looking at the nucleus of optic tract by looking at the OKN, and then it can be one of the methods. What I do is I basically just give them like threatful stimuli, and that can sometimes, again, the same NOT is activated there. Saccades in reading, yeah, saccades are very useful in reading. I did not get the question there though. While you use OKN tape or drum, what should be the size of black and white straps or pocket? Very good question. So basically, I just like manually move it like that. So this is the speed I use. I don't use it very fast or very slow. I typically don't use drum. I typically use the tape. A lot of times now you also get the app on the phone, which you can use too. And in that you can actually adjust the speed also. But again, the issue with any of these is you don't really get a full field OKN. You're looking at the ocular following there. If you really want to use the pure OKN, then somebody needs to sit in a closed room and the things should be moving. So you need a setup for that. What we are doing with the tape or even a drum or a cell phone app is we are looking at the ocular following. Please clarify the difference between gaze-evoked nystagmus and jerk nystagmus. So gaze-evoked nystagmus is a form of jerk nystagmus. So it's gaze-evoked nystagmus is a jerk nystagmus, but jerk nystagmus can be either gaze-evoked or downbeat or PAN, or it can be BPPV, or it can be anything. Whether paratostigmine help nystagmus symptom relief, I typically do not use it for treatment of nystagmus. So I do not have much experience using paratostigmine for that. Mechanism of convergence retraction nystagmus. It's a good question. We did not cover that. It's a complex theory, and it's basically your misconnection between the right to left in the midbrain, and that's then leads to convergence retraction nystagmus. Nystagmus by definition is slow and fast paced. Why then pendular nystagmus is called nystagmus? Very good question. Well, we need a consensus document on that. You're right. It is not nystagmus. I mean, it's not the Greek term for nystagmus. What was the second point in relation to age? What was the second point? Oh, they don't have convergence. So they normally have convergence insufficiency, and the upgaze is typically limited. And the second thing I was telling was Bob Daroff's theory about why upgaze goes first, then the down. Do frontal eye field control vertical saccades also? Yes, they do. Can nystagmus come in myasthenia? You do get a fatigue nystagmus in myasthenia. Okay, next.
I think Okay, somebody's asked one question. All the other things they have said, very nice talk, superb talk, etc. Somebody's asked, in teleneuro consultation, is there any toolkit available for neuro-ophthalmology and fundus exam?
So of course, teleneurology fundus exam is not going to be possible, right? But toolkit, not that I'm aware of. However, as Dr. Kothari knows, he's part of our task force, which we are actually putting together a consensus document. Very soon it will come out, where we will have some good guidelines of how to do teleneurology, neurotology, and eye movements. And we will be more than happy to share with you guys once that document comes out. I wish we had an app or some sort of a guideline for patients to follow while we are doing teleneurology, but not that I'm aware of. I don't think is available, but it is fairly simple to make. You can just make a little video of demonstration and you can give it to patient, or you can publish it on website, and they can go on the website and they can copy that and they can make a video, because making a video at home would be very helpful for teleneurology. They can make a video with their cell phone and they can email you and you can take a look at the video, and that would be very helpful for teleneurology, because my experience is a lot of times over tele, when I'm looking at their eye movements, they're very choppy and I don't really get a very good sense of a fine nystagmus. It's worse than Zoom actually a lot of times. So it's tricky. So
A
video
lot of
is helpful.
myasthenia questions.
Yeah, I know. Well, to be honest, I don't see a lot of myasthenia patients myself, so I have not seen a lot of nystagmus in myasthenia.
No,
They do get some.
You can get
You can get fatigue
You can get
nystagmus and
pseudo-intranuclear ophthalmoplegia.
twitches. Yeah, we generally get fatigue and related to nystagmus. Eyelid nystagmus in myasthenia, I do see eyelid twitches in myasthenia. I have not seen lid nystagmus the way we explained that in the other one. Generally, myasthenia in eyelids, you get ptosis, not the lid nystagmus, because it's inability to move fast, right? So in myasthenia, they cannot move the lid fast and they get just ptosis. They don't get nystagmus. However, I do see in ocular motor apraxia, lid apraxia, sometimes they get this lid nystagmus in apraxia, which is not myasthenia, of course. What instruction do you give to patient while checking OCAN using the tape? So there is a stare OCAN and there is a gaze OCAN. So in the stare OCAN, you just tell patient not to focus on anything, just like keep the eyes open while you are moving the OCAN. So that is your stare OCAN. And the gaze OCAN is you are trying to give them a target as they are looking at the moving strip, and that is gaze OCAN. So there depends which OCAN you are testing. I mean, they're both. Can downbeat nystagmus come in myasthenia? I have not seen downbeat nystagmus in myasthenia.
No. No, it won't be. There won't be spontaneous downbeat nystagmus. When you look down, you may get downbeating gaze-evoked sort of. But
yeah. So yeah, and I think this was a question. Maybe the same person asked this question in the Excel also, the one that I sent. So basically, downbeat, generally we think of it as a cerebellar central etiology. In contrast, myasthenia is generally the muscle etiology. So it's not really seen in myasthenic patients. There are some syndromic entities where you do see downbeat nystagmus with muscle disease, but not the myasthenia gravis.
One last question. We get dalfampridine in India. We don't get 3,4 that the other one.
4AP, yeah. So dalfampridine, as I think.
Can we use
yeah, I think so. Michael Stroop has done some drug trial on that. And there was another drug company who is trying to do that. They actually use it for myasthenia. They are doing it for Lambert-Eaton myasthenic syndrome, right? And that's one of the bigger indication, at least in this country. But for downbeat, I know the company over here was at one point interested in that too. So yeah, I mean, you can use it.
Okay. People wanted to know about this.
One thing you want to, excuse me, one thing you want to be careful about dalfamperidine or any aminopyridines is you want to make sure that you check their EKG also.
And risk of seizures also, no?
Risk of seizure is, yeah, that's correct. The only problem, I mean, the funny thing about the seizure is that there were like isolated case reports about seizures and aminopyridines, and there was some dentist who was actually brushing teeth with that, which is kind of really weird. I mean, it was kind of overdosing it. So that was the reason why there was the whole hype about the seizures. But we very frequently check EKG on people, especially when they get 3,4-diaminopyridine, because it has more of a peripheral uptake compared to the central uptake. So we use that. Do you guys get Fempira? We get Empira here. In Europe, they call Fempira, which is 4-aminopyridine, which is 3,4. Okay. Okay. Yeah. So you could use 3,4-diaminopyridine, but I would just make sure to check EKG.
Okay. Thanks a lot, Asif. I think
yeah.
it went off very well. And thank you for trying out the Slido. I think that also worked well. Next time we'll iron out the problems and we'll.
I don't know what happened about the blurred. It's kind of
something wrong
funny.
with the internet. Too many Americans online, probably.
Probably at middle of night. Okay.
Okay. Good night, everybody. Thank you. Thank you.
Bye.
Bye.